and a very warm welcome to the 2019 annual public meeting of London Ambulance Service. As you can see, things are a little bit different this year, but what I can promise you is that tonight will be as interesting as it is informative. One of the highlights will be our guest speaker, Martin Griffiths. He is one of Britain's top trauma surgeons. He's also the man that the NHS has appointed to tackle knife crime. Also coming up, the public, you, get the chance to put questions to the people that run London Ambulance Service. So there should be a slide coming up now, and I can read you. If you go to www.sli.do and use the hashtag LASAPM, you can put your questions to the people that run London Ambulance Service. I'm also going to get a chance to ask questions to my amazing colleagues that do such a wonderful job here at London Ambulance Service. But before we come to that, I just want to touch briefly on one of the themes tonight. When you see an ambulance on blue lights, you know that it is heading to an emergency. It's going to help someone that needs us. But that is only part of our story. We are working continuously with our partners across London to make sure that we provide the best care and the best outcomes for our patients. So let's start by hearing how we work with our blue light partners. And let me introduce you to Fiona. Hello Fiona, thanks for joining us today. So you're part of our tactical response unit, aren't you? So what are you showing people at your stall today?
So on our stall today, we're talking about our blue light collaboration, so how we work together with the London Fire Brigade and the Metropolitan Police Service. And also we've got various units in London that are specialist assets. So you've got my unit, which is the tactical response unit. We basically respond to firearms calls across London. So we go through training with the police service and undergo training to respond directly to firearms calls across London. We also have our, day to day we respond to normal emergency calls, and then during the Thursday, Friday and Saturday nights we respond with the joint response unit, which means we're a paramedic on a first response car, but we're dedicated and assigned to a local police borough, so we are able to have direct communication with the police on scene and with police in the control room, so we can get to kind of police jobs quicker, basically.
So Fiona, the terrible events of 2017 are obviously still very fresh for our service. Can you tell us how you begin to prepare for major incidents like that?
So we work as a team, so we've got 5 teams that rotate on a normal rotation, and we train together regularly. So we're always prepared to a certain extent to what we might get sent to. We do a lot of exercises with the police and the fire brigade to make sure that we can respond effectively to help save lives and reduce harm across the capital.
And Fiona, can I ask you, what is it like when you get a page or a call that tells you that something serious is happening in London?
It obviously makes your heart sink because you think, okay, this is real now. But with our training and because we do respond with the police and the fire brigade frequently, we're prepared to a certain extent to be able to respond. But it is very, very daunting. A lot of my colleagues have been to incidents. I personally have never been to a proper major incident. But it's, yeah, like I say, it's very daunting when it does happen.
But you're really highly trained, aren't you, for this?
Yeah, because we train with the same team every day, we know who we're going to be working with. We all get on really well. We're like a big family, so yeah, it's good.
Fiona, thank you very much for joining us. Well, from one team of lifesavers to another. We're joined now by Sam Wilcox. This is the Community Defibrillation Manager. Thank you for joining us today. So what's happening at your stall? Are you going to be showing us how to save a life?
Yes, we are. We've got the Annie and we've got the defibrillator. So we're going to show you how to do compressions and how to use the defib. Anyone can learn, any age. It's really easy. Everyone should know how to do it.
So is this defibrillator working? Can you switch it on and show us what it does?
Literally, you just open it up and it talks to you. You don't have to have any training necessarily, but it's always good to know what to do with the defibrillator. So you do what the instructions say. pull it out, you've got the pads, you stick the pads onto the patient, and you just follow the instructions. It says shock the patient, you shock the patient.
And the key thing is that you want everyone to learn how to use these to feel confident to save a life.
Absolutely. The more people that know how to save a life, the better. It's really, really important that you know how to do life-saving skills.
And can I ask, how do you work with partners across London to save lives?
So we have over 4,000 defibrillation sites, and we have over 5,500 defibrillators in London, and we work with those people in order to manage and support them, and we always try and encourage them to buy a defibrillator and to buy their training. It's really important that they're supported when they do get one of these machines. People like Marks and Spencer's, transport hubs like London Underground and gyms, so we work with all these different organisations. We also work with the community first responders. They're in collaboration with St John's. These are volunteers that they work for St John's, but they respond on behalf of the LAS. They work in their own cars with no blue light, and they respond to serious medical emergencies.
I'm really glad that you've talked about volunteers because they're really crucial for London Ambulance Service. Can you tell me what emergency responders do?
So emergency responders that we have, our emergency responders, they come from all different backgrounds, all different industries. We have pilots, airline pilots, we have teachers, we have medical students, and they go through a rigorous selection process. If they're then successful, they then go on to do a training program with us up to an ambulance service standard qualification. They then work in pairs from a station in a blue light vehicle and respond for the London Ambulance Service.
Okay, thank you very much, Sam, for joining us. And I would also like to take this opportunity to thank all of our volunteers that help us to save lives across the capital. Right, now, for anyone that thinks IT is boring, then please do think again, because some of the most exciting things that are happening in London Ambulance Service is happening in the digital world. I'm joined by Ross Fullerton, who's our Chief Information Officer. Have you got something exciting to show us?
We've always got exciting things to show you, Sarah, from an IT perspective. This looks just like an iPad, but what this actually gives us is access to real patient data, so that when we're with a patient, we can understand them much better. We have access to who their GP is, who their next of kin is, what their medications are, so we can give them much, much better care on scene. We've been rolling this out from a small group in Camden. We've had fabulous results, genuinely making a difference to patient care. The next step is getting this all across London so that all of our clinicians can access that data, make a real difference to the patients they see. Next step is then about not just the summary care record. That's a real simple set of data that your GP puts in. But what about your hospital appointments? What about other information that are from an urgent care centre or other people that you engage with in the health system? So we're working with the rest of London to get a real integrated view of all of our patients for every provider across all of London to join all that up so they can see our information, we can see their information, and really transform the way we deliver care to patients. It's so easy being on the iPad because this is the first time ever that you'll be able to just log on with your fingerprint, giving secure access to NHS systems. We tried this with NHS Digital, first trust in the country to do it, and the staff love it. So brilliant news and really exciting for our teams.
Now, you've touched on partnerships, but really this kind of thing, you have to work collaboratively, don't you? You need to know what's happening everywhere.
Yeah, and it's a real challenge for a pan-London trust because every bit of London is investing hugely in technology and delivering patient care improvements. So we work really closely with the rest of the health and care system, but also with colleagues from the Mayor's office, from the fire brigade and the police, thinking about location data, about mapping, about patient data, all those other things that we know we need to do to get to the scene as quickly as possible, give the right care and take patients to the right pathways based on information. And we put all of that in the hands of our crew to use all around London 24 hours a day. So that's really makes a difference to patient care.
And one of the newest innovations is the ability for us to get video from a scene to the control room. Can you talk to me about that?
Yeah, absolutely. So we've been working with an organisation called GoodSam who have got an ability to send a text message from their system straight to a mobile phone. And when that text arrives, it's a fairly complicated process to show you all of it, but the text arrives on here, the person who's got the phone unlocks it and that starts the video. I'll let Stuart unlock his phone to start the video there. This allows us, if there's a caller who, for example, we think we might need to dispatch the air ambulance, this allows us to have which will appear on screen in just a moment. This allows us to identify what's happening on scene directly from our control room. So specialist clinicians can make a real decision around, do we send an air ambulance, do we send a doctor? If it's perhaps a more specialist case, we can understand, is it a major trauma or is it some other kind of clinical complaint that we can give better care advice over the phone to the caller, or we can not send the air ambulance and save that resource for someone else. So real fabulous technology, live video on scene coming straight into our control room, starting that in the next few weeks.
Okay, thank you very much, Ross. So that picture you can see on screen is the logo for the Good Sam app, and that brings me conveniently on to the London's Air Ambulance, because it was a doctor at London's Air Ambulance that developed the Good Sam app, and we are joined now by Jonathan Jenkins, Chief Executive of the charity. Jonathan, thank you very much for joining us. This looks an extremely exciting display you've got here. Can you tell me what's happening here?
On this, I will hand you over to one of London Ambulance Services paramedics.
So what we're doing here is a technique called open heart surgery. So it's a thoracotomy. So basically, these are for patients who have been stabbed, so we need to get to the heart quickly. So what we're doing is we'll do a surgical procedure which then delivers the heart, and what we're trying to do is then looking for a particular wound to the heart.
Can you show us the heart there?
Yeah, so basically...
This looks really...
So this one's been practiced on a bit, but the idea is that we deliver the heart. If we find a wound, we'd either stitcher it or use a staple, and what we're trying to do is actually repair the heart, so that's what we're trying to get to.
So we've met one of our brilliant paramedics, Jason. Can you tell us how the partnership works between London Ambulance Service and London's Air Ambulance charity?
It's our 30th year, so we're one of the oldest air ambulances, and we've just seen our 40,000th patient. Every single one of those patients has been seen by a doctor and a paramedic from the London Ambulance Service. So in terms of working with us on taking interventions out of hospital to the side of the road, in a number of world firsts, including the thoracotomy, the Roboa work, some of the blood work that's been done, we simply couldn't have done that with the unique combination of doctor and paramedic for the air ambulance.
You've recently rebranded, haven't you? You now call yourselves London's Air Ambulance charity. Is it still a challenge to get people to understand that you do rely on donation?
Well, I think, a lot of people do assume that we're state-funded, which the vast majority of our money comes from the people that we serve, the people of London. So we've put the word charity into our name just to help drive that message home. But the service is an exceptional service that's provided by ourselves, the London Ambulance Service, and also our partners over at Barts Health.
Can you just tell me, what does the air ambulance do that can't be done elsewhere?
Well, I think if you look at all the work that the London Ambulance Service does, London is lucky that it has such a world-class service for a world-class city. London Air Ambulance is to do the things that are impossible for the existing resource of the London Ambulance Service. So if it's sort of doing thoracotomies by the side of the road, it's taking the hospital to the patients. So the patients that are so sick that they simply do not have time to get to the hospital themselves. So we have to be contributing something over and above what the London Ambulance Service would ordinarily provide.
And you're a little bit late getting here today. You didn't think to take the helicopter?
No, they don't allow that. Even with CEO privilege, I'm not allowed to fly. But the other thing that actually is really important to note actually about the service is that we are tasked to buy paramedics in the control room down the road at Waterloo, and that is such an art and science to make sure that out of the 5,000 calls that London Ambulance Service gets a day, that our paramedics can work out that we go to the 5 most important a day, and that is probably the hardest job, and Jason may agree, that's probably the hardest job in the service.
Yeah, it's a very stressful job, you can imagine that. Well, that's not the only charity that we work closely with. Let's walk over here to Macmillan. Hello, and I'm joined here by Dr. Diane Laverty. Thank you very much for joining us today. Can I ask what you're going to be showing people that visit your stall tonight?
Yes, we've provided financial support by Macmillan, so we're very keen to show everybody the kind of work that we've been doing. We've got education here to show that for our ambulance clinicians, we're really interested in skilling them and giving them confidence to look after patients at end of life.
Special is this relationship, this partnership between Macmillan and London Ambulance Service?
It's very special. It's absolutely essential for us to get our work done. Macmillan have other relationships with ambulance services outside of London, but actually the unique formulation of what we have created with our team is brilliant with Macmillan. So they've been so supportive.
for families and for patients who are nearing the end of their life to have this extra support from people that are specially trained like this?
Yeah, we only get end-of-life care one chance to get it right, so it's really, really important that we make sure our ambulance clinicians are skilled enough to look after any situation that they come across, so it's vitally important.
So what does that mean? Does that mean having hard conversations with families? I mean, it must be quite difficult as a paramedic or a medic to deal with.
Sure. Often they don't know those people, they have no relationship. It's more about going in there and looking after them with their symptom control, making sure that if they want to stay at home, that they stay at home with that situation. So it's varied. There can be difficult situations and conversations, especially if the patient is very near end of life. Yeah.
I can imagine, though, it's really rewarding to be there with people and families at their most desperate.
It's a real privilege, and I think our ambulance clinicians really appreciate that, but they feel sometimes incredibly uncertain about how to manage those situations. So we're hopefully going to make them feel a bit more confident.
Yeah, because it's still a very difficult subject, isn't it? It's very difficult to talk about death, but are we getting better?
As a society, I think it's very hard, and I think we're trying to push all the time to make dying part of our conversation generally.
Well, Diane, thank you very much for joining this evening. We're going to move on now to our public education team. So, no, we're not. We're going to move on to 111. Hello, thank you for joining us today. So, Jackie and Ina?
No, I'm actually Agatha Norby-Mesher.
Ah, okay. So we've heard a lot about the very special things that are happening here at London Ambulance Service, and one of the things that we're most proud of is our 111 services. Can you tell me what we can offer to patients?
Yeah, absolutely. So the thing is, it's no longer really just a 111 service. So what's behind the numbers actually changed. So what we call it now is a clinical assessment service, because it's actually evolved. So the number stays the same. The other thing that's the same is that there's a 95% target to answer all calls within 60 seconds. So every patient gets gets answered within 60 seconds, and also everyone gets an assessment. And that's kind of where the 111 element stops. Behind that, we have a multidisciplinary team: GPs, advanced practitioners, pharmacists, paramedics, nurses. So it's a bigger team of clinicians that can support patients. We can electronically prescribe, we can direct book appointments. So really, it's kind of changing the service from what we used to call a consult and refer patient service into a consult and complete service, where we can actually try and manage that patient's episode of care within that one consultation. And that's really the mainstay of what we're doing with the 111 integrated urgent care.
So what happens if you phone 111? What will happen when you make that call?
So the first thing that will happen is you'll be answered by a health advisor. They're not a clinician, but they're trained on a very robust toolkit called NHS Pathways. It's a national tool. And they'll use that tool to do an initial assessment, to really just understand what's going on, to rule out any red flag, dangerous symptoms. They can, if they find anything life-threatening or serious, refer directly to the 999 service electronically. So there's no call to 999. They'll send the referral across on your behalf. If after that there isn't anything life-threatening, they will continue the consultation. And basically what will happen is they'll ask you questions to try and understand better what's going on and how they can best help you. Now, sometimes their outcome can lead to a referral or an appointment. But oftentimes it's a more complex situation and actual clinical advice is required, in which case you'll go on a callback queue for a clinician to call you back. And there are different priorities in terms of callback times, but you could speak to any one of the variety of clinicians we have, and it depends on what your clinical need is. And as I said, that person may be able to do a prescription over the phone, for example, or be able to give you clinical advice, or be able to refer you onwards. So that's kind of what would happen on a 111 call.
And am I right in thinking that patient satisfaction is very high?
Absolutely. I think since we've taken over so last year we took over the service for North East London, and we evolved our South East London service into this new model. So we now have 40% of London that we're running through this 111 integrated urgent care service, and what we've seen is the number of calls we're getting from patients is increasing over time, but also the time profile. So we're getting calls earlier in the day, because I think people are realising actually when you call, you will get to speak to a doctor or a pharmacist. You might get your prescription done. So actually I find that people are satisfied and people are calling more and maybe speaking to their friends and relatives. There's never really been an advertising campaign for 111 apart from, I think there was one last winter. So actually what we're seeing is probably that word of mouth and that, I hope anyway, that word of mouth.
Well, Agatha, thank you very much for your time. Well, we're taking a little walk now over to the public education team. And and let's make our way towards Emma Perslow. Thank you very much for joining us, because I know you're very much in demand. Everyone wants you to speak at their events, so I'm glad you took the time to be here tonight. Why is it that you are so busy?
Well, I'm representing the Public Education Department here. So we are here talking about how we work in collaboration with other agencies, in particular the Metropolitan Police, to deliver messages about the consequences of knife crime.
So you take your presentations out to schools. Tell me about the kind of people that you work with.
So I work with lots of other agencies. So as I mentioned, the Metropolitan Police, also London Fire Brigade, teams of magistrates, prison officers, ex-offenders, and we all come together in collaboration to deliver a message about the consequences of knife crime, but each one of us from our own different perspectives.
And how hard-hitting are the kind of presentations? Like, how real do you keep it?
We keep it very real, but we're also very sensitive about the fact that some of these children are quite young. So we deliver the message to 11, 12-year-olds at the youngest sort of end of the scale, up to 18, 19-year-olds. So it's a big age range. So we're trying to be sensitive to deliver the message appropriately according to the age of the young people we're talking to. So we make it very real and very honest, but we're also sensitive to not try and upset the children too much, because at the end of the day we're there to share our skills and experience, but not to really shock and upset them. That's not really the point behind it.
I bet you do shock and upset some children though. What kind of impact do your presentations have on the children and young people that you speak to?
I think they're surprised by some of the information that we give them. So for example, we talk about the body and how it works and how easily you can die from a single stab wound. And they always find that quite surprising, that you can die within a few minutes. A lot of them don't realise that that's the case. A lot of them think that you can just get hurt by a knife, but that you're not likely to die. So that's a big message that we make sure they're really aware of. But also they learn a lot about the sort of work that we do as paramedics, and they find that very interesting. And sometimes some of them ask us afterwards about careers in the ambulance service.
Yeah, so that's part of your work as well, isn't it? It's just educating people about the kind of jobs that they can do.
Absolutely, yes.
And what other things do you teach as well when you're out and about?
All sorts of things. So knife crime is a big part of my work, but also I go into secondary schools and I teach basic life support, CPR as well. I go to speak to younger children as well and make sure that they're aware of how to dial 999 and what sort of messages, what sort of information you need to give if you're going to make a 999 call. I talk to older people as well about strokes and heart attacks. I go out into the community and share messages about what I do in my work and the ambulance service in general.
Thank you very, very much, Emma. Thanks for joining us. So, from the team that is helping to make London a safer place to the team that is making it a greener place. So, let's make our way over here. I'm now joined by Chris Rutherford. Chris, how environmentally friendly is London Ambulance Service?
So we are improving our sustainability quite dramatically. We've introduced the first of our fully electric vehicles. So our LGMs have got 20 fully electric Nissan Leafs. In terms of our ambulances, the core fleets, we're improving our compliance with the ultra low emission zone. We're currently 54% compliant for the fleet as a whole, and actually that will move up to 74% and then 100% compliant by the time the zone expands out to London. So we're progressing quite well.
So we work closely then with the Mayor of London. Who are our other partners that we're working with?
So we work with absolutely the Mayor on the electrical charging infrastructure. We work with Transport for London in developing Vision Zero is one of the elements. The other element that we're doing is working towards a zero emission capable fleet with them. So we've got some criteria that we've signed up to work towards that sustainable fleet, both in terms of response cars and in terms of our support fleet as well. We also work with NHSI, with the Met Police, Fire Brigade, and most recently with Innovate UK on a special project.
And what is the hydrogen ambulance? Is that like one that goes on water or something?
Absolutely not. No, the hydrogen ambulance is basically an electric frontline ambulance that will be range extended with a hydrogen fuel cell. And rather than based on the traditional box vehicle, it'll actually be based on a super low floor, much more accessible vehicle for the Trust.
And what is our commitment, do you think, to becoming a more environmentally friendly organisation?
I think in all aspects of what we do, it's kind of ingrained in our fleet processes now, where I think it possibly hasn't in the past. So every opportunity, do you need a vehicle? Actually, can you walk? Can you cycle? Can you get there by public transport? Vehicles will be the last in that order. And actually, when we do consider a vehicle now, it will be an ultra low emission vehicle, just to cater off for all of our needs.
And Chris, can you tell me what you're most excited about?
Probably the special projects, to be honest. The Innovate projects. It's a really pioneering project. It's supported by NHS Improvement, and we've worked with Innovate team in the past to try and deliver an ultra low emission ambulance. It will probably be the first of its class in the world when it's done. So I think there's quite a lot of excitement around that.
So a world first. So people are watching what's happening here in London. Yeah,
absolutely. I think there's some interest from the Mayor. I know we've got a date in mind when we're looking to launch it. So yeah, really exciting.
Well, that is very exciting. Thank you very much for spending some time to tell us what's going on. Right, let's move on here now to our very important mental health team. I'm joined here by Ben Laurie. Thank you very much for joining us this evening. Can you tell me what you're going to be talking about at your stall?
So we're talking about the Mental Health Joint Response Car today, which sees in South East London a paramedic and a mental health nurse responding to patients with mental health crisis in a pre-hospital environment. Works in South East London from 11 o'clock in the morning till 11 o'clock at night. And we've just completed our first 6-month evaluation. It's producing some really positive results.
Can you tell me a little bit more about those results? What is the impact of this car for patients?
So because we've got a multidisciplinary team where we've got a mental health nurse and a paramedic joint working, we're able to assess patients, treat mental health and physical health on an equal par, and better signpost patients. One of the main figures that we're very proud of is that our hospital conveyance is enormously reduced. So we're able to signpost patients back to mental health trusts where they can receive better care.
And we know that calls about mental health patients are on the rise. So you must be working quite closely with partners in other trusts across London.
Sure, we're forging relationships with mental health trusts because of the frequency in which we're contacting with us. And today we've got Andy Bell with us from SLAM, who's the Director of Finance, and he's collaboratively working with us.
You'll have to tell me what SLAM stands for.
SLAM is the South East London and Maudsley Mental Health Trust.
Okay. So you work with mental health trusts, and what does that provide for the patient? How does that help the patient?
So better collaboration between the two allows us to signpost patients better. We know that accident and emergency is not always the best place for a patient to find themselves, and so with expertise from the mental health nurses and buy-in from the mental health trusts, we're better able to provide better care or a better patient experience for someone in a mental health crisis.
And for paramedics that are getting a chance to work with mental health nurses, what is the benefit for them?
The benefit for them is to see, it's about an education for paramedic and understanding that actually a specific group of patients actually can be assessed in a better, more acute way, avoiding accident and emergency. The paramedics then can go back out into complex onto their stations and start spreading some of that education and understanding about how better to manage mental health patients.
Because sometimes a busy A&E department is not the best place to take a vulnerable patient. There are other places they can go.
Absolutely. we know for a fact that accident and emergency is not always the best place to take a patient. And we know from the 6 months evaluation that, you know, a business as usual ambulance will take a mental health patient to hospital 55% of the time, whereas the mental health joint response car, with the expertise of the nurse and the paramedic working together, you know, our hospital conveyance is around 18%. And of that 18%, we know that half are because of physical health needs. So there is a place for accident and emergency, but we would say that for better patient care and experience, signposting them back to the mental health trusts is where they should be.
Okay, Ben, thank you very much for your time. Well, those mental health calls come into our 999 control room. Our control room is the beating heart of our service, and I'm joined now by one of our brilliant call takers, Robin. Thank you very much for joining us today. Can you tell me what it is like working in a 999 control room in London? How busy is it?
Exceptionally busy. I mean, we average probably about 5,500 calls a day, can be above 7,000 when it's very busy, and that rate is just growing year on year as demand for the service increases. It is very stressful at times, but very, very rewarding knowing you're helping people every day you go to work.
It must be really rewarding. What are some of the calls that really stick with you?
So some of the calls that stick with me didn't actually kind of stick with me until later. There was a call for a young lad that had been stabbed in a chicken shop. That kind of stuck with me. My first cardiac arrest call that I took, that will always be, you know, in your brain. And some of the more interesting calls where people that perhaps have mental health issues ring up, and they're very difficult to deal with, but very, very interesting.
So you are the first point of contact for families, for patients. So what kind of responsibility does that mean for you?
Oh, it's exceptional responsibility, because I have to get as much information as I can, and the information that I need to help them.
And I expect when it's an emergency, that is not always easy to get, not even basic information like an address.
No, exceptionally. Some people think we know where they are, just magically by calling. We do not. We need to know where you are, and we need to check, we need to verify, which is why we ask information a couple of times to verify exactly where you are, exactly where we can call you back. And some people think we just send ambulances out, and we obviously do not.
So if you're calling 999, what are the golden rules? What should you be saying to the person on the end of the phone?
So what should?
So if you need an ambulance, what is the important information to get across?
Okay, so we need to know your address, and that is exactly where you are. So we will need to know your postcode, we'll need to know your door number, we need to know what area you're in, what street you're in. If it's difficult to find, we'll need information about that. If we need to go to a different street, we need to know everything possible to get to you as quickly as we can.
And we all know that there are times when you shouldn't be calling 999. So what are the times that you shouldn't make a 999 call? What sort of calls have you had when you think, no?
Someone that called because there was a dead fox in the middle of the road, broken nails, things that could perhaps be dealt with by other services, dental pain, things like that.
And what people might not know is that call handlers sometimes can be instrumental in delivering a baby. Has that happened to you? Have you helped to deliver a baby?
Yeah, I have helped deliver a baby, multiple times actually. It's very, very rewarding.
So tell me about the last time you helped to deliver a baby.
Okay, so the last time I had to deliver a baby was a couple of months ago, I think. They just said that they were pregnant, which was all fine. The call was going absolutely fine, and then suddenly the baby's head just popped out. And then we obviously had to deal with that, but the baby didn't come out until the crew got there, which is good and bad. We actually get a badge if we help deliver a baby before the crew get there, but obviously the most important thing is that baby is born healthy.
Those must be some of the most rewarding moments you have.
The baby, yeah, definitely. I'd say very, very rewarding.
A bit of light amongst some of the darkness.
Oh, certainly, because you deal with so much sadness and death that when you actually help create life, it's really, really great. And then when the dad or the mum say thank you after you do that, it's really, really great.
Okay, Robin, thank you so much for your time. Now, you may be wondering why I asked him about babies. That's because we're about to talk to our team of midwives here. I'm joined now by Stacey Robinson. Thank you very much for coming here today. So can you tell me about what's happening here on your stall? I can't see any real babies, sadly.
No, we haven't brought any pregnant mothers or babies today, unfortunately.
You do have something, a baby doll though. How are you going to be using your baby doll?
Yes, so this is just one of the pieces of equipment that we use with our training, so it's easily accessible. So there's the team of midwives in the service now, so there's myself and Alice, and we work for the consultant midwife, Amanda. And one of the main focuses of our job is going around and helping our staff with training. And so this is just one of the pieces of equipment that we use. We've got plenty of kit that we carry around with us across the whole of London doing training. So
I think one of the essential qualifications for your team is a sense of humour, is that right?
Yes, yeah, especially coming into the LAS as well, definitely, yeah.
Now we've heard from our previous guest that when you help to deliver a baby, it's one of the most rewarding moments, but I can imagine for paramedics it must also be one of the most stressful. So how do you help our paramedics deal with something that doesn't happen every day?
No, exactly, I think that's it, and we've learned so much actually from them and the feedback they've given us. Lots of people do tell us that they don't like maternity, because of course as a midwife we love it. It's the best job as far as helping a mother bring their baby into the world. Whereas because of what they see, particularly in a large city like London, we're receiving over 11,000 calls related to maternity in a year. It does make up quite a small proportion of the calls in general that the service sees, but the acuity and the emotion that comes with a maternity call, whether it be the actual birth of a baby or whether when something's gone wrong unexpectedly. And it's a huge responsibility for our paramedics and our emergency ambulance crews, as well as the call handlers in the control room, what they have to listen to. And we've sat there and listened to the calls that they have to talk through families through. It's really traumatic and a lot to deal with. So as a team, we want to just do whatever we can to help improve their competence and their confidence, offer an expert opinion when it's required, as far as debriefing, making sure they can learn from something, and try to bring the best out.
So obviously our teams have got a lot to learn from midwives. Is there anything that you've learned from paramedics and call handlers?
Oh, a huge amount. The learning curve this year has been probably the biggest since I've qualified. The scope of practice of everyone that works in the service is just huge. And myself and Alice and Amanda spend a lot of our time with our system partners, almost on a big PR campaign, trying to tell everyone else what they can do. Because I think it's that they don't do themselves justice, they don't shout loud enough just about what they can do and what they can provide in the care that they provide. So we've learned a huge amount. It really is reciprocal learning. It's not just us talking to them. We're learning a huge amount.
Also, I've heard that sometimes babies get named after the person that delivered them. How many baby Stacys are there out there?
I don't know. Not personally, no.
Okay, well, Stacey, thank you very much for joining us, and I would like to thank all of our guests who've been talking to me this evening. I think tonight just shows what an amazing, caring and clever team we have taking care of you. And talking about caring and clever, we will shortly be handing over to Heather Lawrence, OBE, Chair of London Ambulance Service, who will be presenting the formal part of tonight's annual public meeting.
on knife crime.
Ladies and
I didn't mean to interrupt. I got excited. Sorry. I got excited. I'm going to go now. I was just excited. I'm going to maybe go that way. Can I go that way?
Sorry, that's fine.
Good evening and welcome to the APM annual public meeting, not general meeting, of London Ambulance Service. A very warm welcome to you all, particularly to our partners who are here to help us showcase what we do with you all in the capital to save lives and provide emergency and urgent care to Londoners and those visiting the capital. I have a couple of housekeeping things to do, which is, could you please turn off your mobile phones? We aren't expecting any fire alarms or anything of that nature. So should there be a fire alarm, we need to go to the exit signs and our staff will help you get to the exit. And if you need help, flag it up to people, please, because obviously if there's a fire, there won't be lifts. So that might be tricky. So, as I say, the opportunity tonight was really to showcase some of the work we do with all of our partners, whether it's air ambulance, the fire brigade, the police, mental health providers, maternity, a whole range of different providers. And I'm sorry if I haven't mentioned you all, but I hope you've had an opportunity to walk around and look at the stands. We are very proud of what our staff do with everybody. Before we go much further, I want to tell you that the board members, executive and non-exec, are sitting in the front row, and hopefully you've had an opportunity to meet them during the earlier bit of the evening. So what we're going to do now is I'm going to invite Professor Karen Brohey, a non-exec director on the board, to introduce our guest speaker.
Good evening, everybody. Good to see so many people here from all over London. So I am the Pan-London Director for Major Trauma, and obviously violence is a big part of the work that trauma systems do, and especially that London Ambulance Service is having to deal with on a daily basis. And in recognition that we need to be part of the solution in terms of reducing violence activity as well as treating it. A number of measures have been happening across London. One is the establishment of the Violence Reduction Unit that Lib Peck, who is here, leads. And the other one that NHS England London region has done is instituted a parallel network to the London trauma system, the Violence Reduction Network, which my colleague who is also a trauma surgeon at the Royal London, leads, Martin Griffiths. I think the reason for putting it on the agenda today is that prevention is a big part of the NHS plan going forward, and for LAS, they have a number of pioneer services that are aiming to prevent either primarily or secondarily disease, and violence is actually a big one of those. And so many of our clinicians and allied support staff already do work in schools and with the public in trying to reduce violence prevention, and integrating that within the wider system is becoming more and more important. So I'm very pleased to introduce Martin, who will, I think, give you a grand vision for health, and then Lib Peck, who will give a grander vision from the Mayor's office. Martin.
No pressure there then. Hi, my name is Martin Griffiths. Can you hear me okay? I'm a vascular and trauma surgeon. I work at the Royal London with Karen. And we're at ground zero, the epicentre of what we describe as the epidemic in violence in London. And I'd like to say one thing to you first, is thank you to all the LS workers here, who are at the front door, who are the helping hand, who are the first person to receive these young individuals when they're on death's door. And thank you for bringing them to us to give us a chance. You're all heroes, in my opinion, and thank you all very much indeed. So, violence isn't an epidemic in London. It's endemic. It's been going on forever and ever and ever. In 2016, 2,500 knife or gun wounds in London. Last year, 1,400 wounds severe enough to warrant major trauma care within London. And 10 years down the road, our trauma service is phenomenal, and you are part of the best trauma service in the world, bar none. And you have a right to that excellence, that absolute excellence, from front door through to major trauma care, innovation and delivery. You are part of an amazing, amazing service. But the devil's in the detail. We've seen violence at levels we haven't seen for 10 years in our beautiful city. We've seen knife wounds in people who are getting younger and younger. And you know on the front line what that's like. We believe, traditionally, these injuries happen to older people who are in their life, gang members, drug dealers, bad people. But a quarter of what we see happens to people who are 16 and under. And those injuries don't occur in the middle of the night, fueled by alcohol. They happen in the afternoon, between 3 and 5, school time. We know from our major trauma data that the average age of victims is 18. We know that in London, the average age of stab victims is 24. But we know at the Royal London, the most commonly aged to be injured in London is 16. And the second most common age is 15. This is a youth violence problem. So what are we going to do about it? We provide excellent trauma care. We have fantastic vision, great innovation, great research. But we haven't done much about prevention, and it's time for the NHS to step up and work with us. We've been supported fantastically by the establishment of the Violence Reduction Unit, which Lib Peg leads, and I'll introduce her to her later. Hi, Lib. And she is the spearhead of the most revolutionary change in practice in violence reduction the city's ever seen. See more about that. But from my point of view, I have to try and match the amazing work that LAS are doing. LAS have a track record of delivering tremendous intervention and support and prevention in communities, engaging with children, adults, to try and deliver that message about prevention in early years, to try and stop the tide of injuries that are trying to overwhelm us. And they delivered amazing work, bleed control training, intervention with schools, working with myself in the courts to try and decrease the violence there, talking to vulnerable individuals, providing primary and secondary care intervention, setting up novel projects in difficult challenged communities to deliver amazing, amazing results in these young people and support the communities and the families to make these changes. But there's more to do. There's much more to do. And we're going to take the lead that LS have given us and run with that. This fancy job title here is quite interesting, isn't it? What does it say? Clinical director, fixing stuff, basically. And my job is to get the rest of the NHS working to your standard. It's to recognise that prevention is the key to supporting our community, and the community have to be listened to and supported. So what am I going to do, apart from talk to you guys? First thing I'm going to do, I'm going to listen. Listen to everybody, particularly the workers on the front line, the community I support, the workers who do delivery, and the people who live and die in this great city. We're going to sort out our data. We collect information about everything. We don't know what it's about. We don't know how to share it. And we've all been doing this work and not knowing where this information goes. And we need to ask the right questions at the right time to the right people and use that information wisely to share it with effective bodies to deliver not just suppression, not just enforcement, but support, education, training, skills, aspiration to the population we serve, the young people who are too young enough to vote, but old enough to die in our city. And we need to make sure that all our lines join up, that we deliver work that is effective and evaluated. And part of what I'm going to do is make sure this work is evaluated appropriately, that we look at all our interventions to see that they are working. And if they aren't working, we'll change them. We're brave enough to innovate, to make mistakes and change because of those mistakes. And we'll find a way of working with our communities and ask them what they want and what they need to make things better. Because we have to do that. We've tried prescribing care, haven't we? We've tried telling people what to do, telling people not what to do. But we've never made a better offer. Never made a deliverable offer to the young people who are at risk. We've never said to them, what do you need and how can we help you? We've never checked whether our interventions actually work. Whether what we do to people, for people, works. Well, it's time to start doing things with people and asking them what to do. And it's time to be humble and accept that in the past we could have done better. We're going to make our systems work. We're going to find the work that works so brilliantly. The great work you're doing in the courts, the great work you're doing with me has to happen and move forward. We have to franchise that, expand that success, celebrate our wins, and make sure that every individual in the country recognises that London is at the forefront of delivering this change, that every individual in London has the opportunity to deliver on their potential. Doesn't have to be scared about walking down the road at 3 in the morning or walking back from school at 4 in the afternoon. It's very difficult to talk to children in a bleed control training session and be told they would come here by taxi or tube, but they wouldn't walk to me because they're scared of crossing 3 or 4 boundaries. When your child has to risk assess walking home from school, you know you've got a problem. And that's where we are. The political will exists to recognise the benefit of long-term intervention. The NHS has stood up and recognised it has to make a change. And we're going to make those changes now. We're going to look into supporting early years intervention. It's not going to be about flashy things in the front door. I appreciate what it looks like doing something life-saving, but I'd much rather not do the operation in the first place. I'd much rather talk with a young person and give them the skills to move on and make those choices. Give them the capacity, the resilience to deconflict, to stay at home, to say no to adverse opportunities, and also to make choices because they've got the opportunity to make the best choice for themselves, not the least bad choice. Because the violence we see in our city is situational. They're not bad boys and bad girls doing bad things to each other. It's not about race. It's not about circumstance. It's not about demographics. It's about poverty. Poverty of resource. Poverty of aspiration. Poverty of support. And we can change all of that. And you're doing that in LAS now, sending that message loud and clear that you can be everything you want to be. About support, aspiration, diversity, acknowledgement, innovation, failure, and delivering past failure. So what happens next? We take on board your work. We develop a network of clinicians who are passionate about care. We celebrate our successes. We spread that knowledge. We have a coherent voice for London. We make sure that we set the pattern, we set the tone, not for the country, but for the world. Because we all deserve this. We all deserve this. Now I'm going to finish, thankfully, by acknowledging the work that you guys have done, acknowledging that I've said far too much about negative, and recognise that our opportunity here is to capitalise on the positivity in our community. For the first time in my lifetime, all the agencies, law enforcement, local government, large government, social services, education, are on the same page. We all recognise there's work to be done. We all recognise it's time to listen. Multi-agency working, the public health approach, whatever that might mean to us all. It's about understanding. It's about listening. It's about communicating transparently and accepting that in the past we could have done things better and making better choices. I truly believe if we give young people better opportunity and the ability to deliver on their potential, we can make London a healthier and happier place. But the work starts in early years and it's long term. So, before I say goodbye, can I introduce to you my colleague, Liv Pegg. She's the head of the VRU and is going to be the person I'll be working with very closely to help deliver this amazing vision for London. Thank you all very much indeed.
Great. Well,
thank you very much for inviting me along today. I won't thank you, though, for allowing me to come after Martin Griffiths, because that was a real tour de force, I thought, about why we should really confront the realities of our city and get on with providing some solutions in a really joined-up way. And you could tell from his contribution how passionate he feels about it. I do want to start, however, by thanking all of you. I'm talking about violence reduction. You are the people who are seeing the impact of violence on a day-to-day basis, literally kind of mopping up the aftermath of dreadful incidents and tragedies. And I think that takes real bravery, and I think that takes real professionalism. So thank you very much for that. My own journey into working, as Martin said, as the director of the Violence Reduction Unit, and I've been in the post marginally longer than Martin, but it's only 6 months, so we're talking a small amount of time, was as the leader of Lambeth Council, where I experienced far too many violent incidents in the borough, and how we worked with communities, and that word is with communities, is absolutely key to how we kind of get and develop an approach that is going to be effective in the long term. It was also an experience for me that made me, and something I like doing anyway, is collaborating with lots of different organisations. But the thing that sticks with me most is having to go and visit many of those families in those communities and respond to challenges, but meet and look into the eyes of those very often mothers who'd lost a young child, and just seeing played back to you the real helplessness and hopelessness that they felt at that moment. And that's the thing that keeps me kind of ticking along and thinking why this piece of work is so absolutely vital. It's a passion the Mayor of London shares. About a year ago, he announced the set-up of a violence reduction unit. He knew there is absolutely no way that you can enforce your way out of crime. And let's be honest, violence rather, but let's be honest, over the last couple of years we've seen a bigger increase than we would all want to see in violence, and I think bring graphically home in terms of some of those dreadful images we see in particular on our streets. And looking around, you could see some really good examples of things elsewhere in the country that were working. And I have a similar kind of what does public health approach really mean, as Martin articulated, but what you can see is that it was adopted in certain places with effect. And Glasgow is often talked about and is hugely different to London, but nonetheless, when you see a reduction in violence and you start to see some of the factors that have enabled that to happen, I think you've got to look at that. And you've got similarly when you look overseas and see some other examples. So Sadiq set up the Violence Reduction Unit. It was very much around, as it says on the tin, trying to reduce violence, but also alongside that to increase the feeling of safety of Londoners and to make sure that we really put communities and young people at the heart of that. And the approach towards that is really collaborative. That is the key bit. I know from being a local authority leader for 6 years and also being a local councillor, I've seen firsthand the kind of impact of austerity on our services. But the point is we still have resource, and that resource can be more impactfully used if we come together. So collaboration is very much at the heart of what the London VRU is basically trying to achieve. It's also very much around making sure that while we think we can have an impact in the short term, we've absolutely got to be keeping our eye on the ball for long-term sustainable change. And it's really only when we've got communities and young people at the heart of driving that change and us supporting, shifting that power dynamic, that I think we will see those results that we all really long for. So to give you a sense, and I've only got a few minutes, to give you a sense of the kind of things that we are supporting at the moment, it's looking at that early intervention piece. It's providing more support for young children who have been affected or caught up in domestic violence. It's really focusing on schools where we know that exclusion rates are far too high and have been going up at the same time as violence has been going up in the capital. There's surely some correlation at the very least between those. It's making sure that we're building a better transition from primary to secondary school for young people, building their resilience, and it's also tackling that thing that Martin spoke about, which is we've got the data, we know when people are most vulnerable, we know that 3 till 5 after school finishes is a key point. How can we put in more resource more effectively and work with local people? And then critically, it's about that community and that young people. We've set up a kind of young people's action group that is informing our work, but more importantly, giving them some of the tools and giving them some of the money and the resource to go and do things that they want to test and that we can evaluate. And supporting communities in the aftermath of terrible tragedies. We focus in, understandably and rightly, on some of the parents that are most affected by those murders. But actually, the repercussions are far wider in a local area, from friends to extended relatives to just community and neighbours. And what can we really do to support people? And that's part of growing and supporting some of those initiatives at a really grassroots level that have that kind of relationship with young people that can really change their lives. And so youth workers, a much neglected area, I think, of a much neglected profession, is something that we also really need to be working with and supporting in a way that they haven't been over a long period of time. So that's some of the things we're doing, but I really wanted to emphasise a point that Martin raised, which is, I think, the sense of, in a very bleak and desperate situation in London, and it doesn't look that much better nationally in some regards, does it, on a whole range of issues, there is a huge amount of activity going on, a huge passion. The number of times people come up to me and say, what can I do? How can I help? And they've not necessarily been directly affected. And it's for us, I think, to harness that, to use the collective evidence we've got to make those meaningful interventions, to really evaluate and to really make sure that we are genuinely supporting people. We're doing all of the things that I've mentioned in collaboration with organisations, and it would be great through Martin to work more closely with you, looking at the kind of support workers need on the front line, hearing and being able to promote some of the stories of the work and the experiences that you've had from dealing and working with victims. But I think most importantly, to come together and know that this isn't the kind of society we want to live in, and that we can all make a different society if we've got a common message. So thank you very much for inviting me this evening, and I hope the rest of your AGM goes well. And I look forward to hearing from you and continuing my collaboration with my colleague there, Martin, who I will make sure I speak first next time. Thank you very much.
Hashtag live is LASAPM if you want to do some social media. I think we've got time for a few questions. Martin and Liv, are there any questions for Martin and Liv about what they're doing or what we can do while we have them? Yes, lady here. There's a microphone coming.
Yes, thank you. It's been really interesting to hear Liv and Martin talk about trying to reduce youth violence. And I certainly agree that youth services are really important, but obviously they have been very badly affected by austerity. And I was wondering if there are any plans to, perhaps in national government, to actually make youth service a statutory service, properly funded, so that councils could actually do more work with young people before they end up being seen by the youth offending team or other interventions.
I think Martin's indicating, Liv, this is one for you. Sorry. Difficult question. Do come up.
Yeah, thank you very much. I do think the tide is turning a little bit. I think people are realising that youth workers play a key role. And I was in Newham at the end of last week, and they've decided to employ 33 youth workers, which is quite amazing, actually, given the fact that local authorities have by and large in London seen at least a kind of 50% reduction in their budgets over the last decade. So that's an impressive step. And I know, although I don't know of any other local authorities that have gone quite as far as that, there are some that are also talking about supporting that. The only other thing I would say is that it's not always youth workers employed by local authorities. You know, there are a huge range of community groups that have youth workers and do an incredibly valuable job. And I think the support needs to be given to those as well. But I'm all for more people having that key relationship and that often transformational relationship with young people. And we will advocate for more resource, obviously, coming from government.
Thank you. Any other questions? Yes, lady there. Thank you.
Hi. This question to Lynn. You mentioned something about the initiative started a year ago by the Mayor of London, and I'm curious, why is youth violence not reduced since then? I mean, so what has the initiative done, and why has it not reduced the violence? Actually, we have a spike in knife crime.
Microphone needs to go back if you could. Thank you. Right.
Well, I think what I was trying to refer to was that he announced the setup of a violence reduction unit about a year ago, and a lot of work was done with partners to try and bring together the relevant agencies, so the police, the probation service. We've obviously talked about the NHS, public health, local authorities, thinking about how we can have a short-term impact and a longer-term impact. So I was really talking, specifically about the unit and saying that I'd been in post for about 6 months. So, it's early days in one way to try and shift what I think needs to be a big shift in culture and a big shift in the way we work. But in terms of actually the context in which we're working, there is a huge challenge out there, and part of I think our combined job across all those agencies and working with the communities and with young people is to analyse exactly what's going on and try and make sure that we're putting our resource, that's money and time, in the right places, and then evaluating the impact, which is a point that Martin raised about evaluation being key to this.
Anything? Yes, Martin.
Thank you very much. I just wondered that within schools, children very often feel, if they're subject to bullying, that it's very hard to speak out. And I wonder whether this is sort of one element of this problem, that the ability to be able to express fear as a child to another adult within the organisation, and for those fears to be taken seriously and for action to be taken, I think may be something which is quite important, because in a way it relates to the tradition of bullying. And I know this is a rather more severe form, but I just wonder whether that ability to listen to the child, to hear what the child says and to take action is something which is really quite fundamentally important.
Martin's going to reply. Thank you.
Thanks for the easy one. So you're absolutely right that the hidden voices are the ones we should listen to most keenly. And we know in our work in schools, well-being and mental well-being of young children is critical. So we've done some amazing work in school for the mental health information team. We've done some work with CYP Trailblazers, and we've adopted this whole school approach to make mental health and mental well-being part of the metric of what a good school looks like, and to change the attitudes of schools towards speaking out, being supported, and being a fully rounded personality. Not so much about exam results, but about being the person you need to be. And I think that we've had great results in changing that narrative around that sort of thing. I appreciate there have been initiatives around bullying specifically, but we do know that these measures in the appropriate environment, when they're resourced appropriately, are incredibly effective and give these kids not just resilience, but capacity to move forward. So we're absolutely correct in your statement, and we're making steps in the right direction. Thank you.
Thank you. I can do one last question, and then I know Martin needs to go, and we have our statutory bit to get on with.
Thank you. My name is Rosa Gomez. I'm a counsellor in Redbridge. I wanted to ask you both, what is the best way to engage with young people? The ward that I represent has thankfully not been in the news, but violence is very close, too close for comfort. The Judge Fields ward in Redbridge is relatively, what shall I say, okay. But being the school governor as well for Judge Fields School, I am worried about young people. East London has seen quite a few murders in the last time, well, as you have stated in your statistics. So what I want to ask you, how can I best engage with young people to help them believe in themselves, and as a counsellor for me to support them? On the 26th of October, I have organised a youth event in slightly deprived area of Redbridge for 12 to 17-year-olds. So I want to listen to their opinions, to their needs and wants, because I feel it's about time we stop patronising young people, but for local government and politicians to listen to them for a change and take it from there so that we can put resources into place precisely for their future.
Can I make a suggestion that we put you in contact with Liv and talk about that separately, because it's quite a detailed piece of work. You've got a specific event in mind. Liv, would you be happy, and Martin, perhaps to talk to you? We can give you connections this evening. Okay, thank you. So could I ask you all to join me in thanking Liv and Martin? Thank you very much. I think we could spend all evening talking about this very important topic that touches so many families and lives, and indeed our staff. But unfortunately, we do have to move on to the formal agenda of our statutory duty for an annual public meeting. And the first thing we need to do is to approve the minutes from last year, which seems a long time ago now. It was held on the 25th of September in the London Fire Brigade headquarters. So for people who were present, can I ask you if we can confirm these as a correct record of the meeting? Yes, I'm hearing some yeses. Thank you. That's fortunate. So it is our statutory duty to report on our performance, to look back over last year as well as looking forward, to look at what we've achieved in quality, financially and general performance. And it's my great pleasure to invite Garrett Emerson, our Chief Exec, who has led all those changes and developments and achievements, to come and address you on the matters. Thank you.
Hey, thank you very much, Heather, and good evening, ladies and gentlemen. It is my pleasure to talk to you this evening around the year that LAS has had since we last met in this forum at an annual public meeting. So I'm talking about the financial year 2018-19 that we report on. And much of what I'm going to say is actually on your seats or in front of you in terms of the summary version of our annual review, which I will commend to you as an excellent document. So this time last year when we met, as Heather says, at the London Fire Brigade headquarters, we were, I think we were celebrating the achievement of the organisation in removing itself from special measures as an organisation and achieving a new Care Quality Commission overall rating of good and outstanding for care. That was indeed a significant achievement. So this year has perhaps been a year of consolidation and building on that good foundation work and developing an organisation that is sustainable and capable of delivering high quality care and excellence, clinical excellence for our patients on an ongoing basis. At the beginning of the year, we launched our new vision and strategy as an organisation back in April 2018, and indeed we were already talking about it at last year's AGM, with its vision to transform the organisation really from one that focused primarily on the delivery of ambulance services to one that is really the key integrator of access to urgent and emergency care right across the London healthcare system. To transform ourselves, I say, from being seen primarily as frankly the back door of the emergency services to becoming the front door of the whole urgent and emergency care system across London. It was an ambitious strategy, it remains an ambitious strategy, and it remains one that we cannot achieve alone, one that relies us working ever more closely with the wider healthcare system and indeed with, as you have just seen, the wider public sector across London in terms of delivering some of the more challenging outcomes that we aim to deliver. We've seen a number of major steps forward in delivery of that vision through the course of the year. Probably the most significant have been the launch of 2 new integrated urgent care 111 services in North East and South East London. So in addition to responding to nearly 2 million 999 calls every year and delivering emergency ambulance services, we now respond to nearly 750,000 111 integrated urgent care calls. And these services are not, frankly, like the vast majority of 111 services that are around up and down the country. They are much more sophisticated in that, in terms of the clinical capability that we have in our integrated urgent care clinical assessment service, the CAS, as it's invariably called within the system, which is transforming the way we deal with urgent care services across 111 and delivering a much greater level of consult and complete, i.e. we can resolve a patient query on the phone or in our control room call centre, or indeed with transfer and working in an integrated way with the wider system, particularly in terms of primary care and so on. Difficult to underestimate the scale of the challenge in doing this, launching these services and developing them. The real opportunity of them is, of course, to allow greater integration going forward with 999, so that, frankly, ultimately it won't matter what number a patient rings, whether they even ring a number, whether it's 999 or 111, or whether they, as they increasingly do, look for clinical advice and help online. We will get them to the right care first time, every time, and we will do it faster, we will do it better, and we'll do it more cost-effectively in a way that supports the wider healthcare system across London. That is the vision of our strategy, and that is what we've started achieving. We've also started doing that over the course of the year in terms of what we deliver in terms of ambulance services on the ground, with the development and now delivery of some of our pioneer services. You would have seen around the room a lot of what we're doing there in terms of the development of our urgent care advanced paramedic service, with our mental health care service, and more recently with the development of bespoke falls service in North West London, all of which are delivering better, faster, more appropriate care to patients, enabling us to see and treat more patients on scene, in location, whether it's in their home or so on, and reduce unnecessary conveyances to emergency departments, which is, of course, the most pressured part of the whole healthcare system in London. So we're playing our part in the smoother running of the healthcare system as a whole across London, which is, again, very much that vision. We've also played a wider role there in terms of our relationship at the centre of that system, particularly in terms of the management of winter and the increased role we play in the winter room centrally across London, managing and coordinating and improving the intelligence with which we convey patients around at times of high stress and high demand, working closely with acutes and indeed across our own services to reduce delays at hospitals, both in terms of handover to hospitals and indeed in terms of getting ourselves back and ready to deal with the next patient quicker. We've seen our crews deliver significant improvements in hospital handover delays, over 100 hours a month saved in terms of delays at hospitals, which is putting more ambulances and more clinicians in front of patients faster. We've been very active in terms of recruitment. We've recruited over 850 new people into the organisation to put ourselves in a far stronger position in terms of our overall staffing than we have been for a number of years. And all of this has contributed to further improvements in operational performance. You'll see the headline statistic on the front page of our summary review is that we now respond to our highest acuity patients in an average of 6 minutes 38 seconds, and that's against a national standard target of 7 minutes. So we're significantly in excess of that and one of the fastest responding services in the country. And overall, we're judged by a total of 13 measures of performance, which relate to call handling, relate to response times, and relate to patient outcomes against all of the other ambulance services in the country, of which there are 10 others, and we are typically considered to be and ranked in the top 3 performing ambulance services in the country by those measures. So by any measure, we are delivering now a very high level of service for Londoners, which is, of course, only right and absolutely what they expect. And we're doing that in the face of inexorable increase in demand. In fact, the months of December and January were our two highest recorded levels of incident of any month on record across the service. And the fact that we're able to deliver those kind of levels of performance against that kind of background of demand and acuity is a testament to the hard work and dedication of our crews and all of those who support the frontline activity. We've continued to invest as an organisation, invest in new vehicles, over 80 new double-crewed ambulances and various other types of vehicles, including 20 all-electric vehicles that are now in use for our location group managers to work around the service, and we continue to work towards the development of more alternative fuel vehicles in the future, such that we can contribute our part towards the health agenda that is related to air quality, which of course the Mayor is leading on more broadly across London to such great effect. Investing in new equipment, making sure that our crews have the right equipment, their equipment is properly maintained and so on. So examples of that include rolling out improved equipment to assist with helping fallers back up and so on. And we have continued to invest in our people. We have had a culture of excellence when it comes to clinical training and making sure that our crews have access to the best possible training we can provide them in terms of clinical skills. We haven't historically perhaps spent as much time and effort investing in the development of our managers and our leaders, and that has been a big focus for us over the last 12 months. We've introduced our Leadership Development Pathways programme with a total of 5 levels of management training and development, from first-line management and managing essential skills right up to transformational leadership at the senior level. And we have now run a number of cohorts of training and development for senior managers looking to right that previous wrong. We've been active in terms of improving engagement with frontline staff, encouraging freedom to speak up. Our Freedom to Speak Up Guardian, Katie Crichton, has done a huge amount of work on that, much of which you will see focused in the summary report, and is now the chair of the National Ambulance Sector Freedom to Speak Up group. We've seen a massive increase in the number of staff coming forward and raising all manner of issues that enable us to act, often where we wouldn't have previously been able to act, to improve patient care, to improve staff welfare, to improve workplace experience amongst those who work in the organisation. And I am really proud to say that the National Freedom to Speak Up Guardian's Office has adjudged us to have the most improved freedom to speak up and openness culture of any NHS trust in the country, not just ambulance trusts, any trust. So I think that is a real testament to the progress that we are now making as an organisation. We have transformed, I think, the way we recognise and reward staff, particularly in relation to our annual staff VIP awards, to reflect our new organisational values, our values of respect and professionalism and innovation and collaboration. And we saw many examples of how staff on a daily basis were rising to the challenge of delivering on that agenda. And we were also incredibly proud to see in the New Year's Honours list that 2 of our staff got recognition. Our Director of Operations, Paul Woodrow, received an OBE for his services over 28 years, I think, for the ambulance sector. And our then Head of Emergency Ambulance Services, Pauline Cramner, who has now risen to the lofty heights of Director within the organisation, received the Queen's Ambulance Medal too. We were very proud of that. Can I also just say thank you briefly to Martin and Liv for their excellent presentation and their focus on violence and reduction. They rightly praised the work we do at the front line in relation to responding to major trauma. But I also want to point out some of the work that is perhaps less seen by our organisation, and that is the literally hundreds and hundreds of hours that our staff give on a voluntary basis to go out and do training and education in schools and work with underprivileged groups to demonstrate to them both first aid and safety and so on, and also to provide a greater understanding of the impacts of issues like knife crime and so on. There is a lot of work that goes on, but there is also more that we know we can do. The Chairman, Heather Lawrence, and myself were very privileged last year to attend an event run by the Prince's Trust at Clarence House around knife crime, and I think we both came back with a real understanding of that focus that indeed Martin and Liv both highlighted around the youth nature of knife crime and violence in this country, and what more could we do to play our part in that area. And I think partly as a result of that, we've come away and strengthened and now adopted as a trust our new volunteering strategy, which seeks not only to look at what goes on in terms of more senior volunteering and more full-time volunteering, and I know there are a number of our emergency responders and community first responders in the room tonight who contribute literally thousands. I think it's 23,000 hours they contributed last year of support on the front line in terms of responses. But we think there's more we can do in terms of encouraging young people to get more involved in our organisation. We are told that many, many years ago we had a cadet scheme. We haven't had one for many years. We are now looking at how we can do that and how we can develop a new focus on cadets, not necessarily focused purely on clinical volunteering and work on the front line, but actually focused on some of the many, many jobs and skills that we have across our organisation. The many skills that go towards putting our frontline crews on the road there. And if you actually open up your brochure leaflet to the centre pages, you will see in the centre there, you'll see a frontline response that we typically provide to our patients. If you open it up more fully, you start to see all of the people that contribute towards that frontline response, whether they technicians and mechanics that work in our fleet operations, whether they're IT specialists, whether they're HR specialists and other corporate services, and so many other people. We think that A, they don't get quite enough recognition in terms of what they do, but B, we think that through developing our work with young people, we can offer windows into more careers and more opportunities that will help us as an organisation develop the skills of the future that will help in turn London sustain its place at the forefront of not only trauma response but also emergency and urgent response right the way through the whole range of incidents that we respond to. I'd like to say thank you to each and every one of you in the organisation that provide that service 24 hours a day, 7 days a week, 365 days a year, and I look forward to working with you again over the next 12 months to improve what we do for the benefit of Londoners even further. Thank you.
Thank you, Garrett. I think that's a very helpful look back at what we've done and the progress we've made to date. I now would like to invite Lorraine Buse, our Director of Finance, to present to you the annual accounts.
Good evening, everybody. So it is my pleasure to present the statutory annual accounts, a summary of those. And what I'd just like to say is there is a link to the detailed accounts, I think, on the website, and it's also, the link is on the agenda at the bottom. If there are any sort of questions of detail on those accounts, I will be around after the formal meeting's over, happy to discuss that. So I'm going to present a summary of the accounts in terms there are 4 statutory duties that we are required to deliver. And I am pleased to say that the Trust has met all of those duties for the year ended 31st of March 2019. The first duty is that we are required to deliver a capital cost absorption rate of 3.5%. This is the rate set by the Secretary of State for our public dividend capital payments, and they are designed to cover the cost of capital, and that was achieved. Secondly, we're required to meet and not overshoot an external financing limit, and this is effectively a control on net cash flows. We must not overshoot that. you are allowed to undershoot it. And in this respect, the Trust actually considerably undershot. We had a target of 13.2 million cash, and we achieved 20.4 million. And that was achieved through a higher than planned cash balance. The third statutory duty is a capital resourcing limit, which is effectively our budget for capital spend. And this was achieved. We had a budget of 21.8, and we spent pretty well all of that, 21.5 million. And that underspend has been carried forward into 1920 to meet planned commitments this year. And then finally, sometimes the headline statutory duty is to achieve our break-even, and that is now in the current world actually to achieve a control total that is set, and that may be a surplus or a deficit in a large number of trusts. We had a target of 4.4 million surplus, and we actually achieved 6.9. I think what is important to understand is that the surplus position is very much underpinned by non-recurrent funds, which are called the Provider Sustainability Fund. And this has been a mechanism which has been, I think, quite effective over the last few years to achieve incentives to all parts of the NHS in order to deliver the national control total. And as part of that, the Trust took advantage of an incentive to actually increase its control total last year in order to support the delivery of the overall national outturn. And as a result of that, we have got, I feel like, a 2-for-1. So we overachieved by 2 million, and we've been given 4 million of cash, which we've now committed into our capital budget. So I think that was an important thing to do. What is important, though, to understand is that that surplus position for last year, as I say, was underpinned by non-recurrent funds, which will are not occurring in this year. And for 1920, we do have a number of challenges to meet our current target, which is to break even, but we have a plan to deliver that. And then finally, whilst not a statutory duty, we are required as a public sector organisation to pay our suppliers within 30 days as best practice. And here we have two measurements, one around the actual volume of invoices, one around the value. And broadly, the number of invoices was slightly lower than last year's, but the value of invoices paid was a significant improvement on last year from 72% to 88%. But broadly, we've maintained the position on that. And then finally, just want to confirm that these results, which I've just set out, have been subject to an external audit. Our auditors, Ernst & Young, are required to present their opinion, and that is across 4 aspects. But I'm pleased to say that these accounts have been established. The opinion is unqualified, and that Ernst & Young have concluded that the accounts presented are a true and fair view. Secondly, they're required to consider the detail of the annual report, and there are a number of disclosures around remuneration and staff, and those have been reviewed and no issues have been identified. Thirdly, the consistency of the numbers and the words in the annual review have been reviewed, and our auditors have confirmed that those are entirely consistent. And finally, the auditors are required to express a view on our value for money, and the absence of a statement is a very good sign, and we have had exactly that. So no comment, which means that proper arrangements are in place to secure economy, efficiency and effectiveness. So I'm very happy to commend these results to you tonight. Thank you.
A good, clean set of accounts. So now we move to our quality account, and it's a pleasure to invite Dr. Patricia Bain to present those.
Thank you, Chair. It's always a privilege to come here and share the work that all of our staff do every year to provide high-quality care to our patients. So I'm going to talk to you about the work we've done in 2018-19. Just to set the scene in terms of our Care Quality Commission standard, as Garrett pointed out, we moved out of special measures and went to good. We are in the middle of this year's CQC inspection, which we will conclude tomorrow, we hope, and the results of that we will share with you as soon as we have them. Just want to talk a bit about our strategy overall. We set this strategy out 2 years ago. And just in terms of building the culture in the organisation around patient safety, about quality improvement, we have seen year-on-year improvements through our staff survey, through our incident reporting that shows we have a very healthy patient safety culture, and all our staff deliver the quality improvement targets year-on-year. Excellent reporting. We started at about 10 excellence reports. This is where staff have done something really positive. We're now over 350 this year for the work that staff are doing over the course of the year in terms of improving the care for patients. We are now in a position where we've aligned all our quality strategies to our business plans, to our overall strategy, and we have got quality plans in all sectors and across the corporate levels, which are monitored closely through to the board. We have, really importantly, trained over 100 staff now in quality improvement methodology. We are now at the point where we have a cadre of people who can take forward system and trust-wide improvement projects, which we will start over the next 6 months. And we are going to start that in terms of our Right Care, Right Patient programme that Fenella and the team are leading on. And importantly, we monitor that and strengthen our governance processes. So done a lot more around our governance and assurance. We have an operational compliance group now that really focuses on that via Brian Jordan. We have really comprehensive performance management reports. And we have Health Assure. I know it was painful, but we are there in terms of the sectors now having a standardised approach to measuring their quality standards from the floor right through to the board. So a big achievement in terms of that. If I move to the quality account for patient safety, I talked about Health Assure there, and Garrett's talked about all the work that we did on handovers, which was a collaborative approach across the system. Thousands of hours saved in terms of patients receiving care through ED departments. We have rolled out our secure drug rooms, and we have another 5 to go through this year to complete that target from last year. And we have increased the number of defibrillator downloads. So when patients have a cardiac arrest, we monitor that. We were in a position where we were only downloading about 5% of those strips of information. We are now at 30%. What that does is allow us to learn from that in terms of how we manage cardiac arrests and feed that into our training and education programs. And that has seen a decrease in our defib incidents, although we continue to monitor that. In terms of patient experience, we have a team of people who work with our frequent callers. And again, this is collaborating across the system. Some of our patients, frequent callers, some of them will be calling us around 600 times a day, and you can understand the impact that has on meeting the needs of other patients. So where we focused our efforts in North Central and South West, we have reduced the number from 3.8 per thousand to 3.4. We are trialling a different approach in the Perfect Day. Please note, 30th September in Croydon. The Perfect Day, where we will be managing the frequent callers and handing them over to the care of the community during that whole day, and then making sure they're monitored so that they're not ringing in, and we are managing them in a slightly different way. We have developed and worked with others on our patient involvement strategy in terms of involving patients and stakeholders, public, in our programmes of improvement, particularly the pioneering services, and that's called Whose Shoes. It's really been evaluated really well. And we have a Whose Shoes event for the End of Life team, which is happening next week, and I'm sure a lot of you will be attending that. And again, in terms of our maternity, Garrett talked about our pioneering services. We are seeing a reduction in managing the patients who hemorrhage from 96 to 91% in terms of conveying them to ED. In terms of clinical effectiveness, one of the things we did last year, based on our learning from incidents, our understanding of the training and education programs we did a complete root and branch review of our training and education programs. That's about how we report it, how we manage it, the environment that we have, the quality of training that we give. And so we are now taking forward a quite comprehensive training program, training action plans across, which is being monitored through our People and Culture Committee. I've talked about our quality improvement training, and we have also completed our roster reviews. We aim to do 2. We have done a trust-wide review of rosters that now is in place, and we are managing them and monitoring them on a quarterly basis. Rather than leaving them till the end of the year, we will monitor them ongoing to make sure that they are working. And that's all feeding into our operational management plan that the operations team are now taking forward. So the staff survey, again, excellent results. We had 65% response rates, one of the best in the country, a big increase on last year. Significantly better in 34 questions, certainly in terms of positive feedback around the safety culture, and an increase in the staff who would recommend the organisation to work with us. So we start our next survey, I think it's in the next 2 weeks. We have lots of survey champions across the organisation, and we hope we will continue to improve on those results next year. In terms of our priorities for 2019-20, one of the areas we are really going to focus on is our staff safety and support for staff in terms of manual handling. It is one of the biggest reasons why our staff go off sick, and it has quite a significant impact on sickness rate and days lost. So there's quite a variation across the sectors. We are currently analysing all of that, but Garrett's wish is to have a 0 sickness rate for MSK injuries by, when we've worked the trajectory out, we'll tell you, but hopefully in the next couple of years. So watch out for the signs, 0 MSK injuries at every station, which we hope to put up soon. We clearly are going to continue with our pioneering mental health response cards, one of the areas where we've probably developed further than the others at the moment, and we are currently working with South East to roll that out across that sector by the end of the year. And then we will have a plan to roll that out across the whole of London, which people are absolutely really thrilled about and really keen to get involved in, because it is showing really significant results, certainly in terms of ED conveyance. The business as usual is around 54% for a mental health patient. Using this response, it's around 18%, so it really does have a really positive impact on patients. We will also continue to monitor and review our integrated urgent care. Clearly, it's part of our wider strategy. We really need to make sure we have the quality indicators and that we're meeting them on a regular basis. And we will also continue, we hope, hope's not a strategy, and we will continue to be the top 3 ambulance services in terms of our AQIs. And as a well-led organisation, which we believe we are, we will continue driving quality improvement through our various mechanisms that we've put in place over the year and with our staff, and clearly start to develop and deliver on our strategic objectives in 2019-20. So I'd just like to thank you for listening to that. I think, again, significant progress we make this year on year. I'm always proud to say that. Really a big thank you to all of the staff. This isn't about me, it's about all of our staff doing all of this work day in, day out. And we will continue to do that and continue to improve and strive to sustain that improvement in 2019-20. So thank you.
Thank you to Garrett, Lorraine and Tricia for that good, I think, run through many of the achievements from last year and looking forward. We now have some time for some questions. We do have some coming into us on something called, I've forgotten the name of it. John, what's it called? Slido. Oh, right. Are we going to do my thank yous first? All right, we'll do my thank yous first. So I'd like to join Garrett in thanking all of our staff and all of our partners who have come to demonstrate how we work with a great inclusive style to deliver care. I would like to thank the charities that we work with. Could I have the next slide? Could you do the technology for me? Thank you. So here are the charities we've worked with throughout the year, and I don't want to call them out, but I think it's important that we give recognition to the many partners we work with. And there are many more, but those are the main ones. We also want to thank all our volunteers. Last year, 255 people volunteered on the front line. They contributed over 38,000 voluntary hours and treated nearly 15,000 patients. I think you'll agree that's a huge contribution. And of course, we want to thank our Patients Forum, who also have volunteers who also work with us. But I think I want to add to that, because we've thanked quite appropriately all our staff. I think these achievements don't happen by chance, and so I'd like us to recognise Garrett and the executive team, who really do work very hard to work with the rest of the organisation, the management team, to make this happen. And I'd like to give them a round of applause too. And of course, the executive team will have a mixed view on this, but some of that achievement happens through the challenge that's provided at the board. So I'd also like to thank the non-exec directors who are here, who play an invaluable role in chairing subcommittees and helping us go forward. So thank you to the non-exec group. And I would just like the comms team all to stand up, please. Don't be shy, stand up. Because this sort of, stand up, you're not standing up. So, Anthony as well, go on, everybody, Pauline over there, Niall, where have you gone? I can't see you now. But actually, these sort of events, hiding, come out, you're meant to be standing up. These events don't occur without an awful lot of planning. Producing the annual report, the glossy document, the inclusivity, but getting our live programme, John fixing all the practical arrangements where we are today, the venue, which has been great. All the work that's gone into getting the stands here is the comms team work, so I'd like to thank you too. And now, John, if you'll allow me to, I'm going to take some questions. Is that all right? So, if you want to submit a question online, you go to Slido. Have we got some already? I think your plan was to take from the audience, but alternate. Yep. So, yes. Okay, so I've got a gentleman here.
Hi, I'm one of the patients group members who has a look at the performance of not only LAS but also CCAM as well. Yeah. If I could ask Garrett two questions and one for Tricia. The two questions are the opposite sides of the coin. The first thing, there was no mention about the progress towards diversity in LAS in relationship to the profile of London. Has there been positive progress?
Perhaps.
Or, you know, what is that positive progress? Because I did ask a similar question last year. And the second part of that, it concerns EU people.
Yeah.
As you know, there are challenges already with the EU people in relationship to being involved in the NHS. Yes. Yeah. And many of them are in the London and South East area, but don't go much further. So it would be useful to have an update on that. And for Tricia, looking at well-being, I do note the positive things that Tricia is thinking of doing and what is in hand. But one of the aspects of both reports from CCAM and LAS over the years has been issues with regard to bullying and harassment, etc. and it's also about tackling those issues as part of the wellbeing strategy. I'll be grateful for some comments on that.
Thank you. Do you know, before Garrett answers, I remember your question from last year, and as I was sitting here, I thought actually one of our quite big achievements is about diversity from the board down, and there are so many things to cover we didn't. So Garrett, would you like to give the answer?
Yes, there's limited to 10 minutes. Can you get everything in? I mean, diversity and improving diversity in the organisation is and has been a significant priority, not only for myself, but also for Heather, and she has, I think, championed from the day she joined the organisation as chairman, doing something about what is been a significant challenge for us. So I think about 3-4 years ago, diversity in terms of black and minority ethnic representation in LAS was just 11% of the workforce. Now, in the context of ambulance services, that looks quite diverse, but within the context of London and the community that we serve, that is really undiverse, because London itself has a diversity of around 43%, as does the NHS generally in London. So LAS was a significant outlier, and indeed that's the case nationally with ambulance services. And I know the National Department of Health diversity leader, Von Coghill, has 3 priorities in her portfolio. 1 is nurses, 2 is ambulance services, and 3 is London. So I score very highly on 2 of those 3 accounts, and indeed I was co-opted by her to be a member of the National Race Equality Strategy Group, which has been immensely helpful for us. But I am proud to say that we have made significant further progress. We now have a diversity rate in excess of 15%, pushing up towards 16%. That is slow but steady progress. You might ask, how can we go faster, and so on. There are 1 or 2 challenges for us. Literally a third of our workforce is made up by qualified graduate paramedics. The national graduate paramedic workforce in this country that is produced by the education system is 7% diverse, and we're trying to recruit 43%. And even in London and the home counties, it is only 8%. So there is a big challenge there, and one that we are taking up not only across the wider health service to raise the profile of this problem, but also directly with the education, tertiary sector in education, because we feel there needs to be some much broader action to diversify the workforce to which we look to recruit. And you may ask, of course, that we recruit significant amounts of people from overseas, particularly from Australia and New Zealand. I have to tell you that the challenge there in terms of diversity is exactly the same. So there are some challenges for us. We are making significant progress, but it will not be an overnight job to make our workforce look more reflective of the community at large. But that's not the only area in terms of overall representation. It's also about improving workplace experience and the experience of people from black and minority ethnic backgrounds. There are a series of 9 nationally adopted race equality scheme indicators against which we are judged and measured, and they include measures that relate to the staff survey and so on, where we are seeing improvements and where we do fare relatively well now in relation to many other trusts, NHS trusts in London. And the last one that I think Heather referred to is the metric that talks about our senior level leadership and board representation, where we now have much more significant representation, not only on the board itself, but actually in senior roles across the organisation at level 8D and above. So all of those things we're focusing on, but I finally say it is not only about racial diversity, it is also about all of the protected characteristics, and the work we're doing now to develop and improve our disability representation and access to services and employment and so on, and also from all of the other protected characteristics. I won't attempt to go through every single one of them, but I will finally say, and it gives me the opportunity to introduce a brand new colleague of ours, Ali Lane-Smith, who has joined us just in the last 2 or 3 weeks as Director of People and Culture, comes from the West Midlands Police with a very stellar career track record of championing diversity in all its forms, and I am looking forward very much to working with Ali to take our focus on diversity to an entirely new level. You asked about Brexit, and you asked about representation of employment from European countries. London Ambulance Service has very little representation in its workforce from EU countries. I think we, at the last estimate, have now less than 100 EU nationals in the workforce. There are some number of EU workers in some of our suppliers, but even that number is not high and is going down. So in terms of our preparedness for exit from the European Union, that is one of the areas we have looked into and considered, but it's not thought to be a major risk of ours. But there are, of course, a whole host of other things that we are doing and continue to do to make sure that we are prepared for whatever eventuality presents itself.
So I think we should leave that question and move on to bullying and harassment one, which do you really, Ali, do you want to answer that one, or is it a bit too new? Do it together?
Let's take a collaborative approach. It's teamwork. Okay, so we have done an enormous amount of work on bullying and harassment over the year, and it has been reflecting in our staff survey. So what we have seen is improvements in terms of bullying and harassment from managers to managers, etc. But what we haven't seen is an improvement on peer-to-peer bullying and harassment. So that has remained static. So lots of work going on with Ali's team that she will soon know about and lead on in terms of improving that even further. But an immense amount of work going on. We are seeing it reflected in our statistics, and I'm sure Ali will take that forward over the next year, unless you want to say anything.
Yes, just today. So what we've been able to do is to tap into wider work that's happening across the NHS, that's happening with some of our partners. I'm bringing some of my learning from West Mids Police and working with our team of HR advisors, HR managers, to make sure that we are really, really clear on how we can support both employees as they bring forward queries. I've been absolutely blown away by the Freedom to Speak Up Guardian. That's not something that I've come across before, but I think that's a wonderful thing to have built into the organisation. It was really encouraging to hear that actually across all of the Guardians we're seen as really strong in there. So continue to encourage people to speak up, and then to make sure that we can respond to the issues that are raised. So we need to do some work to make sure we can do that consistently, we can respond more timely. That's one of the other messages that we get. What you will find, actually, the better you get at it, the more people come forward, which I know sounds counterintuitive, but that's actually a sign that you're getting better. And we want to make sure that we're in people and culture, we're well equipped then to respond and support both our employees and their line managers to deal with those issues.
Thank you. Thank you very much. Thank you. So I'm not, here we go. So one that came in on, what's Slido? That's it. So you can read it. Do we have plans to improve your buildings and estate? I smile because we spent some of the board meeting on this very issue today, wondering why these types of events aren't run at your headquarters or training facility. Okay, so I'll answer the second bit. Who's going to answer the first bit? Karen, you want to? Okay, perfect. So we want to, when I arrived at LAS, there was a bit of a view that we only spoke to ourselves and were a bit inward looking, and we want to be out in the community. We haven't chosen a plush place costing a lot of money. We want to be out in the community where people are as part of the city. That is the reason. And actually, we don't have a room at headquarters that would take this number of people. So it's partly practical. Kadir, so our Chief Operating Officer, who had the lucky job of also being in charge of
Kadir Mir, Chief Operating Officer, really pleased to be here and join London Ambulance Service. Just in relation to this question, so we've only been discussing this afternoon our estates vision for the London Ambulance Service, which we have been also sharing with staff and our staff side representatives. The reality is, within the NHS, we're working in quite a capital-constrained environment. And so making big announcements and big decisions around capital investment at the moment is quite a challenge. Having said that, we do have a vision and that was endorsed by the board this afternoon. And I suppose just a few headlines on that vision. So we recognise that in London we operate across somewhere in the region of 87 different sites across London. So the London Ambulance Service operates out of 87 different sites, and somewhere in the region of 68 ambulance stations. We've got some of the oldest estate in the country of any ambulance trust, and we have the greatest square footage, essentially, of estate in the smallest geography of any ambulance trust. So there's a huge opportunity, but that opportunity we're going to have to work through in terms of how we realise, in terms of whether we need to reduce the number of ambulance stations we operate out of, and whether we look to consolidate our corporate estate, which we're looking to do already. But we're going to have to do that in an opportunist way. So we know, for example, there's already a compulsory purchase order in relation to the ambulance station in Romford, and therefore we have to work with our staff and local stakeholders in relation to the future of that ambulance station. So we've got a vision. It's been shared at the public board today. We can share that more widely. We are discussing that with our staff. We are sharing that with our union colleagues, and we'll be working through in terms of the next steps what that means in terms of how we realise that vision within the context of the challenges around capital investment within the NHS more generally.
Kadir, thank you very much. Okay, so I think we're back to taking a question from the floor. Gentleman at the back, I will come to you, Malcolm.
Hi, my name's David. I'm actually a community first responder. It's just a question. I wonder if we could have a bit of exposure for our role. I know we're just kind of at the bottom of the ladder of responding, but just a thing on the path, what we do, because most of us done the future quals, which means we do ops, and so there's just a sort of basic thing on the path, because a lot of crews in the centre that I come into contact, and this is my patch, aren't kind of aware of what we are. Recently had an arrest, the crew thought I was a first aid at an event, which is fair enough, but that was all just a little paragraph.
Anthony, do you want to just quickly respond, or? It's a very fair point.
I think it's a very easy question to answer, which is yes. I've been at London Ambulance Service for my 6th week. I did my first proper ride-out with Ian, sat there, and John, and it was with the ER, so the emergency responders. Absolutely blown away by what they do. I met a couple of guys since Stratton and Wayne, 2 BA pilots. I think they were on strike at the time, so they didn't have much else to do that day. But no, absolutely fully behind talking more about what all of our volunteers do, the emergency responders, the community first responders, the people who do the work supporting defibrillation, and also then obviously promoting our volunteer strategy. So we have a massive vision to recruit a lot of new volunteers over the coming years. So to be able to talk about the work that people already do is a major part of that.
Thank you. Thank you. Have we got another Slido question? I'm learning something. I didn't know what Slido was. I do now, though. So will we be using the lighter ambulances as shown at the emergency service show? This is one of Garrett's favourite topics, so I think you can read the question. Garrett, you better answer it. And while you're on the topic, why don't you talk about emissions? Briefly.
It's one of the favourite topics. It's a topic that I invariably get collared with having to answer, and sometimes people look at me and look at my past career and my current career and say you're ideally suited to play these roles and so on. So we are doing a lot of work towards developing what I would euphemistically call an ambulance of the future, or the ambulance of the future. It's something that we started a couple of years back working at a London Ambulance Service level. Now, as a result of a major review of ambulance services across the country led by Lord Patrick Carter, one of the very right and proper conclusions of that is that we needed to work much more closely together as an ambulance ambulance sector to both design, develop and procure our vehicles. We are individually quite small players in the global vehicle market. Just to give you some conception of that, the number of ambulances bought by all of the ambulance services in the UK every year keeps a company like Mercedes-Benz busy building chassis for about a morning. So we are never going to individually have any sort of say in terms of shifting the market and changing the views of the manufacturers, the major manufacturers, as to what they might provide and develop. And one of the challenges for us there has been the lack of suitable vehicles available for us to do our job. And the challenges is because the demands we place on them, both in terms of the amount of equipment we put in them, the amount of power they need electrically and so on and so forth, make it quite a challenge. So as a result of this, a lot of development work that's now gone to develop a joint and coordinated approach to both buying ambulances today and developing ambulances in the future. We are now working and we are now leading, and for my sins I am the Chief Executive who's been designated by the Association of Ambulance Chief Executives to lead this work for probably obvious reasons. The national project to develop the innovative ambulance of the future. And for me that has to have a number of characteristics. It has to be low emission, zero emission capable, because although we live in a city that already has a low emission zone, they will be developing other low emission zones in other parts of the country, in other cities, and it will not be long before we have not only low emission zones that we have to work in, but zero emission zones, areas where the only vehicles allowed in will be zero tailpipe emissions and so on. So it's important we develop a vehicle that is zero emission capable. That means it's got to be electric or electric hybrid driven and so on. But it also needs to be light. It needs to be lighter than the vehicles that we have at the moment. And this is the point about the C1 licence, because the C1 licence is something that if you're my age or older, indeed if you're over 40, I think, or 41 or so on, you will have that on your licence automatically, because it used to just come with the driving licence. But if you're any younger than that, you won't, because this is the part of the licence that allows you to drive vehicles over 3.5 tonnes. And of course that is a challenge for ambulance services and other services up and down the country to train and enable people to drive those vehicles. So we regularly have a large number of staff who are clinically trained and able to go out on the road and perform their duties, but are not trained up to drive our ambulances because they are over 3.5 tonnes. So getting a vehicle that is lighter makes our job easier and makes us able to respond to patients and so on. And I suppose also what we want to do is make sure that we develop a vehicle that meets the challenge that was put earlier around musculoskeletal injuries, and Tricia rightly pointed out my ambition around having a vision for the future, zero musculoskeletal injuries for our staff. A big part of that is around the nature of the vehicles that we use, and that frankly doesn't matter what type of vehicle you've got, whether you've got the vehicles we use here in London that have so-called box bodies on them, or whether you have the van conversions that are used in some other parts of the country. Neither of them are very good from the point of view of access and the point of view of generating musculoskeletal injuries. So we are developing a new vehicle of the future. It will be some time before it appears on the road, but we hope in the next 6 to 9 months we will start to see the development of prototype initiatives and so on, that are low floor, much more accessible, zero emission capable and lighter. That, I believe, is the future of ambulances in this country.
And while we've got you, we've had the stand on greening our fleet, and I think one of the questions, Malcolm, you wanted to ask was about emissions. Yes, so could we answer that while we've got you?
I know what your question is, Malcolm, but do you want to repeat it, or should I repeat it? This was the one you asked earlier today.
Well, I think we said, this isn't... We were going to give you one, I'm going to give you two. You did ask something about emissions, so I thought as we were talking about vehicles, we could do that one, and then I'm going to give you the opportunity to ask another one. But you have to choose your next.
I'll raise it as a single question, perhaps. By which date will the LAS ensure that all LAS ambulances, MDT systems, are powered by battery instead of idling ambulance diesel? Will the LAS urgently provide guidance to all frontline staff about the importance of only switching on diesel Will the LAS ensure that all stations have adequate and appropriate electrical landlines to charge batteries without running diesel engines? And also, by which date does the LES expect all frontline staff actively to use iPads for communication with control and to receive CMC data?
So just
because there are other people who want to ask
questions from the public and then refuse to answer.
We're not refusing to answer. We're merely saying we need to take your questions in concert with other people. We've got the system streaming online as well. We have limited time.
I think there was a theme to your question, Malcolm, which is really around the use of diesel engines, and I think what you're driving at is around the need that we presently have for our rapid response cars, or fast response cars, to keep their engines running when they're sitting on standpoints to enable them to be able to respond quickly to Category 1 emergencies. So MDTs are mobile data terminals. These are the pieces of kit that are in every vehicle, be it a double crewed ambulance or a fast response car, that connect the crew directly with the control centre, and they're the piece of kit that fires to the crew the next job that they have to do and where it is and the details of it and so on. They have to keep that mobile data terminal active and running, or else they can't receive the message to get the next incident. And if the engine gets turned off and it gets shut down, it takes anything up to 2 minutes for it to rev up again, which of course, given that we are looking to respond to our Category 1 patients within 7 minutes, is a very substantial chunk of time. So sadly, at the moment, we have to keep those engines running, which is not an ideal situation. It's not good for the crews who have to sit in those vehicles and so on, and we would dearly love to have a zero-emission capable vehicle with enough battery power to enable us to do that. But sadly, we don't have the battery technology today to enable us to keep those MDTs running while the crews are sitting waiting for those calls. And unlike the double crewed ambulances, which are working more or less continually from job to job a lot of the time, as I know our crews will know, our fast response cars actually do relatively few jobs a day because they have to stand there and be ready to respond for that Category 1 emergency when it comes in, which means they don't generate a lot of power when they're out on the road by driving around. So it's not really a question of charging them up in the depots, it's really a question of actually the power use on the road, that we don't have the battery technology that you can put in those vehicles today. Where we can use electric vehicles, we are, which is why I went out of my way to point out that for some of our other support vehicles, we are already using electric vehicles. And as the technology develops for cars and indeed for larger vehicles, we will absolutely move to zero-emission vehicles wherever we can.
Excuse me, sir, but you're misleading everyone here in this place. I worked at Bromley Station. I know that the MDT is not. It's on all the time. It's not worked off the main battery. It's got its own battery, which works itself thin. The crews do not leave the vehicles on all the time. Otherwise, the make-ready crew would switch them off because they would be poisoned by those fumes. We've had this question brought up to you many times. To leave these people here that ain't even switched on. So in other words, we're confident you, they would go to an incident and leave their keys in the vehicle, keeping it running, and then when they come back with the patient, the vehicle will be gone because someone had got in there because they've got the keys in it. That doesn't happen. It does not happen. You are misleading these people here by saying that they have to.
Okay, I think
Let me just answer that quickly. It's certainly true to say that there is an additional battery in the vehicles. The vehicles have more than one battery, but all the batteries on the vehicle effectively are charged by the vehicle itself when they're out on the road.
Yes, all they connect into the landline to inside the...
But that's only the case. You can only connect something to a landline when the vehicle is in the garage. If you're asking a question is, can we put electric charging points at standby points, that's a different question entirely. But actually, the reality is that to keep those that equipment operational when they're on the road, we are not in a position where we can turn those vehicles off at the moment.
Okay. Sadly, I think we're now out of time. If there are other questions, we will try and answer them offline. So I would like to once again thank all of you for coming tonight, and thank you for the people who've contributed to stands, to all of our staff. And Kadir, sorry. Pardon? Oh, Kadir, and there is one last thing. I knew I'd do this. There's just one thing we'd like to do. Kadir, come up to the stage. Sorry.
So it's my pleasure this evening just to give Claire Hewer here her 20-year service certificate and badge. But just a bit of background. So on the 24th of January this year, Claire had done 20 years of service in the London Ambulance Service. Claire's one of our emergency response dispatchers, one of those individuals that takes those 2 million calls that we have and dispatches crews and responses within, within an average of 5 seconds. On the 27th of January, Claire was rushed to hospital from work with sepsis. Had two cardiac arrests in hospital, then another 2 in crit care, 4 in total, and was on the verge of kidney failure and other life-threatening conditions, and was told, her family was told to expect the worst. Claire pulled through, and last month returned to work, and I think when it was announced on Facebook that she announced on Facebook that she was coming back to work, I think there was something like 14,000 responses. Phenomenal, a really popular member of staff with 20 years service who was keen to get back to work, and so we're just really, really pleased to award you the 20 years.
Well, thank goodness we have a team to set me right. So, Claire, you messed it up. I do apologise. But we're so glad you're back with us. So, once again, thank you very much to everybody. Safe journeys home. Thank you.